you want to share what you discussed in the group?
I think one of the big things we discussed in patient barriers, I think besides language, like time. You know, you're so hard and busy. I feel like we usually don't have the time to actually sit down and properly talk to the patients. You know, so I think that's one thing that we talk about a lot of barriers.
All right. Anyone else? Yeah.
We talked about for barriers to care, lack of access to the primary care. I feel like that sort of list of primaries on the wall, you can kind of like all the PMDs in our area, which is very inadequate. So patients routinely run out of medications, and we are sort of the safety net. And we fill a lot of the role that primary care doctors do or should, but it's not the patient's fault. Some areas they can just call the doctor when they're running out of meds and they can illness, or they can walk in and patient routinely tell us they don't get seen when they walk in.
Justin, you want
One of the barriers to access to primary care that I encountered is one more of patient education and understanding. If they don't know that when they run out of medication, they can call their doctor for a refill. Say, oh, I ran out, my appointment's not for 2 weeks, so I don't know.
Yeah, I think I agree, but depending on which clinics they go to as well, you can't even get a hold of anyone.
Well, I mean, but I've had that happen with people who have.
Yeah, if it's a private office,
outside,
right? Yeah, I agree.
I'm sorry guys to interrupt. If anyone's been looking at the news, you saw that there was a train derailment at Atlantic Avenue. So I just got a call from Dr. Jackson. They're having a large surge of patients. So if you are scheduled to work at Kings County, if you could please go to your shift. It's kind of, might be an MCI kind of disaster situation.
What about 3 to 11?
No, I think regularly scheduled people.
Any additional people?
No, they told me that just the people who are scheduled, if they could go now instead of at 12, that would be really helpful. Thank you.
All right, so I guess we just finish up. All right, so just a few more minutes.
You guys can go now quietly so that Osagie can continue her lecture. That would be great.
Okay, so last case that we'll go through quickly, 60-year-old woman, history of asthma. She was brought in for her daughter for shortness of breath. She's ready to tachypnic. You also take her lungs while the nurse is getting her vital signs. She clearly has wheezing on exam. But then you feel a very large, hard, right-sided chest wall mass that seems to be coming from her right breast. You eventually get an x-ray and you see this like large punctating mass that's eating up all her thoracic space. So you suspect malignancy, so you explain your diagnosis to the patient and her daughter. The patient says that she's feeling better, that you gave her some nebs. She's still clearly tachypnic, but she's demanding to go home, right? So we all kind of dealt with this patient, basically refusal of care. So I'm just going to touch on some terminology. So capacity is really a functional term that refers to a patient's cognitive ability to understand the nature of what's going on and their effects of their decision. Competency is more of a legal term. It's very similar to capacity. A lot of times it's used interchangeably, but as physicians, we really assess for capacity, not competency. So leaving as medical advice, we've all done it, I'm sure. I signed the patient out AMA. It accounts for 0.8 to 2.2% of all discharges. When you look in urban populations, urban hospitals, disadvantaged populations, that number goes up a bit higher. I saw up to like 6% in some papers that studied it. And so so people who are at higher risk for leaving AMA are those who lack health insurance, those without primary care physicians, those who get admitted through the emergency department, which is at county, it's like all of our patients pretty much. Those who have substance abuse problems and men are more likely to leave AMA. So reasons for leaving that's been cited, so some people have family emergencies or family problems, personal or financial obligations. I've had many patients tell me like, doc, I understand why you want to keep me, but I gotta go to work tomorrow, or I had to go home, get things in order, and then I'll come back. You know, I've heard that many times. Patients who are feeling bored, fed up, or feel well enough to leave. So even though you controlled someone's pulmonary edema, you got them on BiPAP, they're feeling better, and they think they can go home after that, they feel better. Or people who are dissatisfied with their treatment. So the last small group discussion is basically to discuss how you typically assess capacity in a patient wanting to leave AMA, and then talk about a time in which you successfully convinced a patient to stay in the hospital or accept treatment when he or she initially rejected. Okay? So take a few minutes and then we'll reconvene.
So our group was discussing basically having the patient sort of verbalize exactly what you expressed to them in terms of like risks of leaving against medical advice. And one thing I even do is like, what made you come here in the first place? You were concerned about something terrible happening, and now I'm concerned about it because this is what we found. And then, you know, sort of reminding them of that, of why you came in the first place and what you were scared about, what you thought was going on.
and this presented that reality to them, I think,
Right.
in addition.
Anyone ever tried getting like the family members on your side and then, yeah. Wives, yeah. Works every time.
The problem I found with that is that only works until the wife leaves. And then they immediately go back to it, or until that family member leaves, and then they're right back asking you to leave, asking you to leave. So you really have to address why you have to address why they want to leave against medical advice, and sometimes it's something simple that you can intervene on, like a work note or calling to arrange childcare or something, like something simple.
Just from the perspective, like actually assessing capacity of people, I think it's like the rational clinical exam or something like that. I think they have one that discusses figuring out whether or not the patient actually has decision making.
Right. Yeah, you can use tests like that, mini mental status exam. But just know, I was looking at like different kind of tests that you can use. Not all of them, there's no exact answer basically on how to assess it. And just know that there might be some cultural differences as well that may inhibit a patient from carrying out all the functional tests that you're asking them to do as well. Joshua, you had your...
Yeah, in terms of getting the patients to stay, if they're thinking about leaving and they don't have a good reason to leave, like taking care of their kids or whatever, tool I use in my own material is letting the patient know, especially my relationship to the community, is like, I often say, if you were my dad, and I'm taking care of you like you're my dad, I want you to stay. And that kind of changes things for them.
We were talking about drunk people and how they always want to leave.
Right.
The guy basically the other day, he had like some bruises on his face, and he was able to walk, and he was almost on his way out, but I don't know, I had to scan because he had a little bit of blood, and pneumocephalus and temporal bone fractures and everything like that. So it's annoying, but you have to just call hospital police a lot of the time if you drunk people, especially.
That's a good point. So in that case, you said the person was drunk, but just because they've been drinking alcohol, they can still have capacity, or even if someone has like underlying mental illness, depending on how severe it is, or if they're in any psychosis. If they're not, and if they're displaying full understanding, then you can sign them out safely as well.
I think this is something
Special mental illness, think about their motivation.
Right.
If they want to leave because they want to go hurt themselves, versus they want to leave because they want to take care of their 5-year-old child, that's a very different case.
Right.
I think something we suffer from a lot. We had like psych patients. Sometimes we see them talking to themselves, but they're not feeling psychotic. And I've seen in my 3 years their patients get 5 and 2 because they got restrained because someone thinks they're feeling psychosis. Like patient actually saying, "I know my rights. I'm not crazy. I want to leave." So I think it's something we have to work on, like able to examine the psych patients, because I think something is very lacking.
Yeah, and if you have any questions, just get our psychiatry colleagues to come down and see.
But we shouldn't always go to restrain those patients and sedate those patients, or if they're not actively, by spying.
Yeah.
And if you like, I completely agree. And if like you feel comfortable in your capacity assessment, and you feel the patient does have capacity and they understand what you're saying, and they're willing to take that risk, people are allowed to take risks in their lives. You don't have to agree with it, but if they know what they're doing and they've made a thoughtful decision, you gotta respect that.
Yep. And just kind of adding on to it from like Shit's comments and Bloomberg. When you get annoyed by a patient, when it's a patient who is bothersome to you, when it's a patient who you're having to decide whether or not you're going to sedate them, whether you're going to kind of play jailer for a little bit in order to do what's best for them, and you're kind of like, take off. We've all been there. I know we've all been there. I can't be the only one who's like, this patient's killing me right now. You got a full room and you have to do this thing. I've forced myself to slow down at that point because you gotta treat this patient the same way you would a STEMI or the same way you would major trauma. Simply because through your annoyance, you are more likely to skip things and miss things that are possibly important for the patient. And that's what I tell myself every time. And I feel like that patient may not merit all the time that you give to them, but your own well-being as a doctor, you're protecting your license, you're making sure you don't miss something on a patient that later on is going to come as a contact and you feel bad about yourself. And there's all these other small things that do warrant the time that you will dedicate to this patient, even if they know it on.
Okay. All right, thanks for sharing.
And just one more point is also that, you know, like when your system capacity in AMA is it's like a medical legal document. It doesn't absolve you of your clinical decision-making skills and your decision capacity to make a decision for your patient too. So if you're going to discharge somebody or have them sign AMA, give them all the regular follow, all the regular medication, treat them the same as the patient you're still going to discharge, because at the end of the day, it's not like the AMA is going to protect you. It's just a form stating that you have medical advice for a patient that may not have the same medical insight as you, and then they're taking a different form of having a different opinion and a different idea of what they think they need to do for themselves. So that's just another key thing too. It's not like, oh, this guy's doing AMA, I'm good.
Yeah.
Just discharge and get the papers right away. No, still set up an appointment, still set up follow, still set up medications. You know, just try to talk to the patient, just make sure you follow through on everything. Protocol solution.
All right, we're running out of time, or we're out of time. So basically, practicing medicine in the developing world is challenging yet rewarding. I may be a little biased, but I think everyone should at least try it once just to get a different kind of cultural, professional experience. There are similar medical ethical issues that arise both here and abroad, and medical ethics should be evaluated by case basis, and it should guide our daily practice. And here's just a quote